be able to see it.
House Health Policy Committee will come to order. Would the clerk please take the roll?
Chair Rogers.
Here.
Representatives Whitsett. Here. Carter. Here. Hadsma. Neely. Here. Glanville. Here. Coffea. Here. Conlon. Here. Farhat.
Here.
Fitzgerald.
Here.
Miller. Here. Rheingans. Here. VanderWall.
Present.
Filler. Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz. Here. Thompson. Here. Madam Chair, you have 17 members present. You do have a quorum.
Thank you. Representative Kofia moves to approve the minutes from our meeting on February 28th, 2024. Seeing no objection, minutes are approved. Prior to testimony and votes, if you wish to speak or express your position on legislation before us today, please submit a card to the clerk. Sergeants are in the room and would be happy to collect the cards and get them to the committee clerk on your behalf. In the interest of time, you are also welcome to submit written comments to be submitted to the bill record. Today, we will vote on House Bills 5077, 5078, and 5179, which address the opioid epidemic and previously received testimony in the Behavioral Health Subcommittee. I will then send House Bills 4745 through 4749 to the Behavioral Health Subcommittee. Finally, we will hear testimony on House Bills 5345, 5346, and 5013 in regards to contraception access. We will not, I repeat, we will not be taking up House Bill 5114 today. First, we have the chair of the Behavioral Health Subcommittee, Representative Braybeck, to provide her report on the subcommittee's work on House Bills 5077, 5078, and 5179. Chair Braybeck, welcome to the Health Policy Committee, and begin when you're ready.
Thank you, Chair. I really appreciate it. Members, thank you for allowing me to testify. The bills in front of you are very, very straightforward. 5077 and 5078. Those two bills, in combination with one another, they expand the ability of all governmental agencies to distribute naloxone. This is a naloxone, for those of you who aren't familiar, is a medication that can quickly reverse an opioid overdose. So right now what can happen is that these agencies can currently only administer it. So in testimony, we heard an example of a public agency in Port Huron that regularly receives shipments of naloxone from HHS. Because of the lack of clarity in Michigan law, this organization and many others like it are uncertain if they can further distribute the naloxone to other public and private entities. Think our church partners, libraries, nonprofits, all those places that we normally partner with. So I want you to keep in mind, and I know that many of you know the scope of this, but in 2022 alone, almost 3,000 Michiganders died of an opioid-related overdose. 3,000 lives we lost. So by passing 5077 and 78, we will be ensuring that naloxone is put in more hands, which turns into more saved lives. Now, 5179. 5179 deals with fentanyl test strips and the state's definition of drug paraphernalia. We have all heard about the rise in the use of fentanyl and lacing other drugs. And so what this simply does is that it would enable folks who are expecting to use drugs, any sort, let's take marijuana, to be able to test those drugs to ensure that they are not contaminated by fentanyl and with fentanyl, thereby again reducing the chance of accidental overdose and death. So in collection, these three bills really focus on trying to save more Michiganders' lives. Thank you, Chair.
Thank you. Seeing no questions, Representative Filler.
I'm sorry, 5179, this is Representative Rheingans. Is she going to testify? Is the representative going to testify?
No, Representative, these have been vetted in the Behavioral Health Subcommittee, and we are not taking up testimony again today.
Okay, but it's fine to ask a question.
Sure.
Okay. Can you just walk me through what a sort of real-life example, if 5179 becomes law, what looks like? I believe we talked about this, and the discussion was right now if you're found with some of these testing strips, you may a drug paraphernalia could be a misdemeanor charge. I don't know, might be a felony charge, probably misdemeanor. And that this would change that so that would no longer be the case, and the purpose would be to get people clean fentanyl testing strips without the thought that they might get in trouble for it. Is that a broad definition of the discussion?
Representative Rheingans, would you like to answer?
You eventually got there, sir.
Okay. And the negative possibly being that we are things that are drug paraphernalia we don't overall root for. We don't root for drug use. That's not great, but this is sort of like mitigating an ongoing issue. Am I reading that correctly?
The issue is that fentanyl is so potent as a drug, even a contaminant, in with other drugs that somebody might be intending to take, or even if they're not intending to take drugs at all, it could cause an overdose. And there are people who want to use these in kind of more casual settings. And if they're, caught with one of these test strips, they could be prosecuted for having possession of drug paraphernalia. So we're trying to decriminalize this type of drug paraphernalia so that people can keep themselves safe and prevent themselves from overdosing and dying.
Chair, a quick follow-up, and what's the process? How does one prove that, or is there a difference between, hey, I've just got this testing strip, or will they all be decriminalized, or will be you had to get it at a certain place?
So this law was originally created in the 70s, and the way that it was written was to criminalize anything that could be used to test potency. The idea was thinking about, cooking up drugs and making drugs and trying to see if you could test them to be more and more potent. So in the 70s, when this law was originally created, it was just a blanket ban on everything because we just wanted to prohibit people from even being involved in using drugs at all. And now that we're so much farther advanced in our science and our medicine, and we know that addiction is just a mental and a physical health condition, that decriminalizing this one tool in the toolbox for people to practice good public health behaviors, this is something that, law enforcement is not opposed to and is good public health practice to help save lives.
Thanks to you both. Chair, thanks for letting me ask some questions.
The one thing that I just did want to ask, in addition to the potency, the prevalence is increasing. And so and people are accidentally ingesting fentanyl. And so they don't know that they're doing that, and this helps prevent that. Thank you, Chair.
Thank you very much. So reading the cards in, we've got supporting 5077, the Substance Use Disorder Services Directors, and 5078 and 5179. We've also got Avanti Sheth, Wayne County Medical Officer, in support of 5179. House Bills 5077, 5078, 5179, supporting From a Family Against Narcotics. Supporting 5179, Michigan Overdose Prevention. And supporting 5077 and 5078, Department of Health and Human Services. Supporting all three of these bills, Michigan Nurses Association. Representative Roth moves to report HB 5077 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rheingans.
Yes.
VanderWall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Pass.
Madam Chair, you have 18 yeas, 0 nays, 1 pass. House Bill 5077 is reported with recommendation.
Representative Fitzgerald moves to report House Bill 5078 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rheingans.
Yes.
VanderWall.
Yes.
Filler.
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, and 0 pass. House Bill 5078 is reported with recommendation.
Representative Farhat moves to report House Bill 5179 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsett,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Rheingans,
Yes.
VanderWall,
Yes.
Filler,
Pass.
Mueller,
Pass.
Van Workum,
Pass.
Roth,
Yes.
Schmaltz.
Yes.
Yes. Thompson.
Pass.
Madam Chair, you have 15 yeas, 0 nays, and 4 pass. The motion prevails.
Motion carries. Go ahead, Ease, call the chair. House Health Policy will come to order.
Madam Chair-
Representative
Oop, I'm sorry.
Representative VanderWall.
Madam Chair, I'd like to ask if we could reconsider the vote on 5077, please.
We will reconsider the vote on House Bill 507. We will make, Representative VanderWall makes the motion to reconsider the vote on 5077. Madam Clerk, will you please call the roll to reconsider? Yes.
To reconsider the vote on House Bill 5077, Chair Rogers.
Yes.
Representatives Witsett,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Rheingans,
Yes.
VanderWall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, the motion to reconsider prevails.
Motion prevails. Now we will again vote on House Bill 5077. Clerk, will you please take the vote?
Chair Rogers.
Yes.
Representatives Witsett,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Rheingans,
Yes.
VanderWall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, and 0 pass. House Bill 5077 is reported with recommendation.
Motion prevails. House Bills 4745 through 4749 were introduced and referred to the Committee on Health Policy in June of 2023. It is my intention to have Chair Braybuck and the Behavioral Health Subcommittee work on these bills. Madam Clerk, please read the provided letter.
A letter dated March 5th, 2024. Dear Madam Clerk, on June 14th, 2023, House Bills 4745, 4746, 4747, 4748, and 4749 were referred to the House Committee on Health Policy. These bills amend the Assisted Outpatient Treatment, AOT, process. Add individuals authorized to do mental health evaluations for AOT diversions and provide for mediation between a mental health provider and AOT recipient. I am asking the Subcommittee on Behavioral Health to review and make recommendations to these bills. I am confident that the subcommittee will be successful and productive. Sincerely, Julie M. Rogers, Chair, House Committee on Health Policy.
Thank you, Clerk. Now we will hear testimony on a three-bill package, House Bills 5013, 5345, and 5346, that expand and ensure access to contraception. To testify in support of these bills, we will have the bill sponsors, followed by Farah Jalul, Director of Professional Development for the Michigan Pharmacists Association, and David Bright, Professor at Ferris State University and President of Michigan Society of Community Pharmacists. We will then hear from a practicing OBGYN, Dr. Sarah Wallet, who can speak to the need for expanded access to prescription contraceptives. Finally, we will hear from Harsna Shalal, who has a personal story about the effects of struggling to obtain and fill a contraception prescription. The committee will stand at ease. Call of the chair.
The committee will come to order. Chair Rogers, please begin when you're ready.
Thank you. Good morning, and thank you to Representative Young and Hope for working with me to expand access to contraceptives. One of the most significant reasons for inconsistent use of contraception is barriers to access. The bills in this package specifically address access issues and ensure individuals who need birth control are able to obtain it in a safe, convenient, and cost-effective way. My bill in the package, House Bill 5013, requires insurance to cover a 12-month supply of prescription contraceptives if a patient's physician prescribes a 12-month supply. Currently, many individuals are required to go to a pharmacy on a monthly basis to fill a prescription, which could have been provided as a full year supply at the time of the initial prescription. As a healthcare provider myself, I recognize the need for access to adequate healthcare and believe that dispensing a year's supply of contraceptives will help ensure continuous and consistent use. It is often a struggle for working people to find time in their busy schedules to make monthly trips to the pharmacy to pick up a medication that they rely on. If an individual cannot pick up a contraceptive in a timely fashion, they risk sacrificing its effectiveness, as they may miss scheduled doses or forego filling the prescription altogether. According to NCSL, nearly 1/3, let me say that number again, 1/3 of hormonal contraceptive users missed taking their birth control because they were unable to get their next supply. This is according to the 2020 KFF Women's Health Survey. Access issues are particularly relevant for people in rural areas where the pharmacy may require lengthy travel to reach and could be affected by weather conditions on the roads. And if we all have noticed weather in the last 2 weeks, we've had sun, rain, sleet, and even hail. Access to contraception is not just for those who choose to use it for family planning purposes. Many medical conditions, including endometriosis, menstruation-related symptoms, polycystic ovary syndrome, all use contraception as a treatment. Ensuring a year-long supply is provided to a patient will increase the likelihood that they do not run out of these important medications. Finally, the H2 sub before you makes some changes to accommodate concerns by ensuring that the required coverage is for prescriptions that are on the covered person's health plan formulary at a pharmacy within the insurer's network. The sub also includes language that prohibits the dispensing of a 12-month supply if the FDA deems it medically inappropriate, and changes the implementation date from 90 days after enacted to December 31st of 2025. Studies show that receiving a 12-month supply of birth control is a health benefit and will improve proper usage. This is a cost savings measure for both patients and our healthcare system, as unintended complications are prevented by increasing continuous use of these safe medications. NCSL also reports that these studies show a 30% reduction in the odds of having an unintended pregnancy when a 12-month supply has been dispensed as compared to those receiving less than 3 months of coverage. At least 24 other states already require dispensing for more than 1 month, with the most common requirement being 12 months. This has been successfully implemented in nearly half the country, and Michigan is well positioned to join these states, which include Texas, Massachusetts, South Carolina, Illinois, Louisiana, and many others. Thank you.
The committee will stand at ease. Call of the chair.
The Health Policy Committee will come to order. Representative Young and Hope, please begin whenever you are ready.
Thank you, Madam Chair. Thank you for hearing these bills, which are timely and essential to the health of not just women, but others in the state of Michigan. I'll be pretty succinct. My bill in the package would allow pharmacists to prescribe hormonal contraceptives. We've heard a little bit about access already in your testimony, Madam Chair, but just to elaborate a little bit, and I'm sure others will testify to this as well, 1/3 of Michigan's counties have no OBGYNs. This is a problem in rural areas, but it's also a problem in the city of Detroit, which is near the bottom nationally when it comes to OBGYN availability. 29 states and the District of Columbia already allow pharmacists to prescribe self-administered hormonal contraceptives. Over 19 million women, low-income women, live in counties that lack reasonable access to a health center that offers the full range of contraceptive methods. And in a fairly recent survey from 2019, 67% of women said they would benefit from being prescribed hormonal contraceptives by a pharmacist. My bill would allow pharmacists to prescribe all forms of self-administered hormonal contraceptives, including the pill, the ring, and the patch. There's 2 levels of protection here for the patient. Pharmacists would be required to complete a Board of Pharmacy approved training before they're able to prescribe birth control. And then on the patient side, they would be required to complete a self-screening risk assessment before they could be prescribed birth control. I've been working closely with the Michigan Pharmacists Association and Wayne State University's College of Pharmacy. And I'd also like to thank Representative Farhat for working with me on this legislation as well.
Good afternoon, and thank you, Madam Chair. So I come before you today to testify about my legislation, House Bill 5435, requiring insurance coverage for pharmacists prescribing contraceptives. My bill complements the legislation proposed by Rep. Hope, House Bill 5436, which allows pharmacists to prescribe and disperse certain contraceptives, and of course your bill, Madam Chair, House Bill 5013, which requires a 12-month coverage period for birth control supplies. These bills are crucial next steps to continue ensuring reproductive rights for all Michiganders. Having access to birth control is a big part of the right to choose and the right to act with autonomy. According to a recent report, more than 19 million women of reproductive age living in the United States live in contraceptive deserts. We've heard of food deserts. Now there's a contraceptive desert, meaning they lack reasonable access in their county to a health center that offers the full range of contraceptive methods. By opening up this scope of practice for pharmacists and allowing them to prescribe self-administered oral contraceptives, this legislation can help bridge that gap of care. This bill will undoubtedly increase patients' access to birth control. Another important point in support of House Bill 5435 is that patients can also reduce time-consuming medical exams and the cost associated with the visit to obtain a prescription from a pharmacist. My bill specifically requires health insurance companies to cover the prescriptions written by pharmacists for contraceptive care. Around 1.2 million people who live in contraceptive deserts often must find a babysitter, take time off of work, or travel long distances to access their preferred birth control method. These bills together are about improving patient access to safe birth control methods. Trusted members, from trusted members of the healthcare community, which includes our pharmacists. Pharmacists are already trained to educate patients on proper use of prescription contraceptives. They can also provide education about related topics such as complementary forms of contraception that can protect against sexually transmitted infections. These bills are a great next step in expanding access and health care coverage to safe contraceptive and reproductive health care for women in Michigan. With that, I just say thank you for hearing me on today, Madam Chair.
Thank you. And we're going to hold questions till the end because some of your questions may get answered by technical experts. Next, with the Michigan Pharmacists Association, we have David Bright, professor of Ferris State University and president of the Michigan Society of Community Pharmacists, and Farah Jalul, the Pharmacists Association director for professional development. Welcome to Health Policy, and begin whenever you're ready.
Thank you, Chair Rogers. Chair Rogers and esteemed members of the House Health Policy Committee, thank you for the opportunity to provide testimony regarding House Bill 5013, 5435, and 5436. My name is Farah Jalul. I am I'm a practicing pharmacist and the Director of Professional Development for the Michigan Pharmacists Association, who represents pharmacy professionals statewide. Joining me today is Dr. David Bright, a fellow pharmacist and the professor of pharmacy at Ferris State University, as well as, you mentioned, the chair of the Michigan Society of Community Pharmacists Board of Directors. MPA strongly supports the bill presented as they mark crucial strides in expanding birth control access for women across Michigan. Upon a valid 12-month prescription, House Bill 5013 will positively impact patient adherence to contraceptive regimens. Collectively, House Bills 5435 and 5436 will empower pharmacists to adequately assess a patient, order, and dispense the appropriate form of hormonal contraception, thus amplifying the accessibility of this vital healthcare service. Moreover, establishing a reimbursement framework ensures the financial viability of these services within pharmacies while also guaranteeing coverage under the patient's insurance plan. As mentioned by Rep. Hope, currently 29 states and the District of Columbia allow pharmacists to prescribe and dispense contraceptives with documented benefits to public health initiatives, patient access, and health equity. To discuss these benefits in more detail, I will now yield the mic to Dr. Bright.
Thank you. Chair Rogers and members of the House Committee on Health Policy, thank you for the opportunity to speak on House Bills 5013, 5435, and 5436. My name is David Bright, and while I'm a professor at Ferris State University, I'm here today on behalf of the Michigan Society of Community Pharmacists, and my views do not necessarily represent that of Ferris State University. As we mentioned earlier, pharmacists across 29 U.S. states have been empowered to prescribe and dispense hormonal contraceptive products since 2013, meaning that pharmacists across the country have leveraged this authority to improve access to contraception, to reduce unintended pregnancies, and reduce overall health care spending. Michigan has the opportunity to leverage more than a decade of experience and research across other states to drive a strong and successful plan of implementation. I'd like to briefly highlight a few of these findings in other states and then describe how these findings reflect why MPA supports these bills in Michigan. First, findings in Oregon identified that pharmacists quickly began prescribing roughly 10% of all new pill and patch contraceptive products for Medicaid enrollees. And roughly 3 in 4 patients receiving a prescription from a pharmacist did not have a contraception prescription filled in the past 30 days, suggesting that the contraception access was drastically improved. Even after accounting for fees paid to pharmacists for the service of seeing patients and issuing prescriptions, this model demonstrated an estimated cost savings to Medicaid of $1.6 million in the first 24 months. In other states where a clinical payment model did not exist, implementation was far slower and access was impeded. So the combination of House Bills 5435 and 5436 appears to leverage these lessons learned elsewhere to ensure more rapid and widespread implementation of contraception prescribing by pharmacists in Michigan through simultaneously advancing a clinical model and a financial model for the service. Second, Language in House Bill 5436 requires use of a self-screening risk assessment tool that is based on best practices for contraception use. This language closely resembles processes implemented in other states and provides very clear information to drive prescribing decisions. And while there's always fear of making clinical errors with a process like this, error rates in this model are very low and are very consistent with other healthcare professionals issuing prescriptions, whether that's physicians, mid-level providers, whether it's through telemedicine or through a pharmacist. Therefore, the process outlined in House Bill 5436 mirrors the safe practices that exist in other settings and in other states. Third, we've seen in recent years that contraception access issues exist everywhere. And even if you do not personally take a hormonal contraceptive product, I'm confident that most people in the room have at one time or another been to see a physician to get a written prescription and then have had to travel to a pharmacy to obtain that drug product. And while some in Michigan may not have transportation issues, it's been discussed earlier, we cannot overlook these as a potential challenge for some in our state, particularly in rural areas. And not only does House Bill 5013 offer reduced logistical hurdles through the 12-month supply issue, but transportation and schedule logistics would be greatly improved if patients only had to go to a pharmacy and not also to a physician's office. And while House Bill 5436 offers such convenience to patients, data also suggests that patients recognize the convenience and time savings of skipping the physician's office and going straight to the pharmacy. In fairness, I'm sure that reasonable people can hear or read about what's done in other states and still have concerns, especially when I say things like skip the physician's office. Right? In this case, skipping the physician's office sounds like a potential risk to missing other health screenings or care from other providers. However, to quote the American College of Obstetricians and Gynecologists, ACOG Committee Opinion 788, they say, pelvic and breast examinations, cervical cancer screening, and sexually transmitted infection screening are not required before initiating hormonal contraception and should not be used as reasons to deny hormonal contraception. In essence, these bills follow the direction of ACOG in prioritizing access and dispelling fears about potentially lacking health screenings, and instead offer to the patient a pharmacist as a solution. House Bill 5436 includes language about notifying the individual's primary care provider if provided by the individual, which creates a great opportunity for the pharmacist to emphasize team-based care and to encourage the patient to not miss any other critical health needs. Reasonable people may also be concerned that pharmacists may need training before taking on the role of contraception prescribing. But just as the case with many other states where pharmacists have began prescribing contraception products, House Bill 5436 specifically references a training requirement to ensure that pharmacists are appropriately prepared for the task at hand. In this way, it's reasonable to expect that pharmacists can quickly obtain the necessary training to offer a service in a safe and effective way, just as they have in 29 other states. And while it's easy for me as a pharmacist to advocate for pharmacists, I'd like to again quote ACOG Committee Opinion 788, where it states that pharmacist-provided contraception may be a necessary and immediate step to increase access to contraception. The Michigan Pharmacists Association appreciates the work done in House Bills 5435, 5436, and 5013 to empower pharmacists in Michigan to take this necessary and immediate step to increase access to contraception, to reduce unintended pregnancies, and to reduce healthcare spending in Michigan. Thank you, and I would be happy to address questions that may come.
Thank you. I think we're going to bring up a OBGYN and then have questions. From the perspective of a practicing OBGYN, we have Dr. Sarah Wallet joining us today. Welcome to Health Policy, and begin whenever you're ready.
Thank you, Chair Rogers and members of the committee, for allowing me to speak today. My name is Dr. Sarah Wallet. I'm the Chief Medical Operating Officer for Planned Parenthood of Michigan. I'm a physician. I'm a board-certified obstetrician gynecologist, as well as board-certified in complex family planning. I'm a proud provider of sexual and reproductive health care. According to research by the CDC, almost 80% of women have used birth control pills at some point in their lives. And according to the Guttmacher Institute, more than 99% of sexually experienced women have used at least one form of contraceptive in their lifetime. That means this is something that impacts all of us. And it's not just women. Both women, trans men, and non-binary people, as you already heard, don't use these medications just for contraception. They also use them to manage irregular menstrual cycles and alleviate pain caused by health conditions like endometriosis and polycystic ovary syndrome. These medications are safe, they're effective, and very widely used. They have a broad list of benefits, but insurers currently, many of them, only allow people to pick up a 1-month supply at a time. This is an unnecessary barrier that I hear from my patients from all of the time, that they have encountered a refill delay, that they have missed doses. This renders the medication less effective for whatever use they're using it for, and potentially results in an unintended pregnancy. Research, significant research, shows that providing a 12-month supply of contraceptives results, as you've already heard, in less overall healthcare cost, as well as fewer unintended pregnancies. That's why I, as a practicing OBGYN, am strongly in favor of House Bill 5013, which increases access to birth control by requiring that all insurers provide access to a 12-month supply. This policy is actually already in place for Medicaid beneficiaries in the state of Michigan. It's also accessible for people who access contraception through Title X. This bill would allow all Michiganders, no matter who their insurer is, to experience this benefit. I am also supportive of bills which will increase access to contraception by expanding the type of providers who can prescribe them. I am not a pharmacist, but I support my pharmacy colleagues in this. As you already heard, and as an OBGYN I can tell you with my expertise, there is overwhelming evidence that pelvic and breast exams, cervical cancer screening, and sexually transmitted infection screening are not required prior to initiating hormonal contraceptives. Pharmacists are capable and experts at providing medications. Patients are capable of using self-screening tools to determine their eligibility and the safety of using various methods. Patients who live in a community without a health center or who face transportation barriers may find obtaining contraception through the support of a pharmacist, many of whom are trusted in their community, to be more accessible, especially if they don't have a primary care provider or insurance coverage. These bills will help mitigate barriers and ensure that more people, more Michiganders, have access to the contraception they need to protect their health and decide if or when to grow their families. Major medical organizations support these measures: the American College of Obstetricians and Gynecologists, the American Academy of Family Physicians, the American Public Health Association, as well as the American Medical Association. Thank you, and I'll also be happy to answer any questions.
Thank you. Next up, we have a personal story about the struggle to access contraceptives. Harsna Shalal. Welcome to Health Policy, and this is our last person testifying, and then we will go to questions.
Can you all hear me? Oh, perfect. Okay. Hi, everyone. My name is Harsna Chahal, and I'm a graduate student at Michigan State University, acquiring my master's in public health. Additionally, I'll be starting medical school this summer. I'm here to testify for HB 5435, HB 5436, and HB 5013, and be able to share my story on the importance of why these bills need to pass. I started to go on birth control in 2021. The decision to start taking birth control wasn't to protect myself from getting pregnant, but to actually regulate my menstrual cycle. See, at the time, I was a college student at Michigan State University, where I was not only a full-time student, but working part-time. Having irregular menstrual cycle wasn't as simple as, oh, it's that time of month again, let me put a tampon on. I would get severe abdominal cramps, so it would hurt to even sit up or walk around. Sometimes I would get migraines, where I was not only faced with a pounding headache, but auroras, where my vision would go blurry, or sometimes it would completely go gone, causing me to feel nauseous. This negatively affected my academics because these symptoms didn't just last for 10 minutes, but it would last for hours, which would cause me to fall behind on my homework and even occasionally miss class to take care of my health. When I started to get on birth control, it was great. I knew exactly when I would get my menstrual cycle and was able to plan around my homework assignments because I was aware of my when my menstrual symptoms would occur. Birth control helped me regulate my menstrual cycle. However, I came to face other challenges trying to acquire birth control. Being a student, it wasn't easy to have a car on campus. Occasionally I can borrow my family's car, but other times I would have to rely on walking or taking the CATA bus. But this wasn't easy as well. In the winter times, the buses would be filled or not arrive or come on time. Sometimes walking in the cold and the ice wasn't safe. On top of this, it was difficult to get to the pharmacy before closing because of my occasional lack of transportation, classes, and work. One time, I had to wait an extra week without any birth control because my pharmacy didn't have it in stock. Talking with other students, I would hear the same challenges. Some need to acquire birth control to regulate their menstrual cycle, help with their acne, or even protect them from pregnancy. But it wasn't just students. When I worked at clinics or shadowed physicians in the greater Lansing area, I heard patients discuss their own challenges, like relying on the bus to obtain their prescription, which can also be a financial burden because of the cost of how much a bus costs. Doing this every 3 months was a burden, especially when I had classes, academics, as well as my job to focus on. To be able to make a decision for my own health shouldn't be this difficult, especially for other Michiganders. I decided to pursue my public health master's degree and become a physician because I not only want to acquire the medical knowledge to heal individuals, but also help dismantle the various social determinants that are affecting communities' health. And the lack of and the lack of accessible birth control is one of them. As I embarked on my academic journey to become a physician, I want the ability to get accessible birth control for more than just 3 months. On top of this, I want these bills to get passed to help dismantle the various challenges that individuals are facing trying to acquire birth control, many of whom are your constituents. I thank you for the time for listening to my story, and I hope you all do the right thing to help dismantle the various challenges Michiganders are facing trying to acquire birth control. Thank you.
Thank you so much for your important testimony. I appreciate your time. So we do have several questions. I've got so far Representative Filler and Minority Vice Chair VanderWall, if the bill sponsors would like to come back up. And then we also have the pharmacist and Dr. Wallet will just kind of direct questions. So give it a second. We'll see where the questions are going. Representative Filler.
Thanks, Chair. Thanks, Representative Hope, Representative Young. My wife is an OBGYN. We love birth control. We know access to birth control is a wonderful thing. Rephrase, Your Honor.
I will reserve my personal comments for a later time.
MERS
Gonna
quote
end
of
up
the
with
day.
MERS quote of the day, aren't I? Damn it.
Just keep on going, Rep. Filler.
All right, but it's clearly complex because birth control is not just baby related, it's hormonal therapy, and it's used for a lot of different ways. Pharmacists, maybe don't have the training on preeclampsia, family history, what goes into what OBs make decisions on what kind of birth control you use. So I'm worried about that. I'm glad you put in a lot of elements and options that go into the pharmacist training and outreach to the physician, but that's just something that I wanted to bring up to you as a concern I have. And I know it's a valid concern and part of your discussion too, but anything you can offer to that is helpful for me. Thank you. Thanks, Chair.
I hope, Representative Filler, that you get MERS quote of the day, and I also hope that you take some comfort in the fact that pharmacists will be trained on prescribing birth control, and then there will also be the extra layer of protection in the patient's self-screening assessment tool.
I'll just add to that, Representative Fuller. It still is incumbent upon the person seeking the birth control or whatever the use of the contraceptive is to be responsible for their own health. And so if they have some of these underlying conditions, then they would need to know that ahead of time, right? I mean, I don't believe that folks are going into this with eyes wide shut. I believe that there is some background information and that folks will utilize the pharmacist to help educate. And I haven't seen the screening tool that'll probably be used, but we're certain that there'll be certain questions that'll have to be asked. And if you answer yes to this, then I'm pretty sure a pharmacist, and he could join us, but would direct somebody to see a physician if they had pause when it came to prescribing medication.
Minority Vice Chair VanderWall.
Thank you, Madam Chair, and thank all of you for being here today. I guess several questions that I would like to address. First, when we're looking at a 12-month supply, I think that there's two things that alarm or cause a little pause for me. First, if a person comes in and they're on an insurance plan and they get their 12-month supply on the last month, I do see an indirect burden to that insurance carrier to cover that medication when they're technically going to leave. So that was one question I have. The other piece of it is, if we're prescribing 12 months and a person hasn't been on this birth control for a period of time and they have an adverse reaction, then we could be 11 months of product that will have to be destroyed. And I will say that we already know our country has been a wasteful society when it comes to some of these medications. So I would like to ask that question. And then finally, there's one is, a lot of us are on maintenance drugs now, and 3 months supply, it's I look at it as not being out of a burdensome issue to be able to get that. So I understand we want to do 12 months. I think it goes back to the waste, the potential adverse effect, and what do we do with a product that could be 11 and a half months that now we've got to destroy because you can't bring it back to the pharmacy. And then I'll throw one more question in.
We're going to pause. That's
You're gonna
3
pause?
questions. We're
3
going to pause.
questions?
We're going to pause and let them, because I'm starting to have some memory loss here.
All
so.
right, well.
The first question, to restate it, is the 12-month piece. What if people come to the pharmacist in the last month of their health plan and want a 12-month supply?
Well, I suppose that's always possible with any medication. You can typically get a 90-day supply, so I guess your concerns would apply there as well. There's not really any way to prevent that, and I'm not sure why we would want to. I understand the concern about waste, but as we've heard, people who are on birth control are on birth control. Not forever, of course, but it's something that they will continue to need. And if they have it due to a previous benefit that they had through their work or whatever, good for them.
I'm guessing too that, like you said, a wide variety of folks are on oral contraception, and if they started a new plan, I would guess that they wouldn't wait till the 11th or 12th month to get that access. I would guess that they would be excited to be under healthcare coverage and access that pretty immediately. Rep. Young, did you want to chime in at all?
I was just thinking about the young lady who just previously gave testimony and her usage for the medication, and I don't know, I just would consider it a bonus. I mean, it's to regulate her menstrual cycle. And if she should happen to have lost her job, and she wouldn't have been able to get it, I just think it would be a bonus, and I don't see it being a big burden. But I can't necessarily speak to that. That will have to be the insurance companies. That's just my opinion.
And then, Rep. VanderWall, did you say the last question was the maintenance drug piece, the 3 month?
Correct.
What was
Well, basically what I was saying is there's a lot of us that are on maintenance drugs now, and 3 months is not out of a normal strategy of making sure you make your plan to go to the pharmacist. My concern is if we take somebody and put them on a drug, we don't know what this is going to be. Is there the first time you're going to be on a maintenance drug for 3 months and then you could option into a 12-month? I just look at how many people and how many drugs we now waste because we hear everything. Bring your drugs back, put them in this bucket, we'll destroy them. Don't flush them down the toilet. I just look at the waste in what we can do. I'm not arguing, the fact of this, but I think I'm getting to, Madam Chair, is sometimes, if we put the cart before the horse, are we really doing the right thing? Shouldn't they try this and make sure there's no adverse reaction before they can opt into a 12-month?
Yeah, I would just say that the 12-month piece is very specific. So we are talking about oral contraceptives, and we're not talking about the other maintenance drugs that you're referencing. So the bill is very specific to that piece, to that specific drug class.
Okay, I understand where you're trying. I'm just using a maintenance as an example. But if somebody goes and immediately gets 12 months supply and they have an adverse effect, we're dumping it down the drain. And I just think that we're not looking at the long term of what this is.
Did you have a fourth question? Sorry, I paused you.
The last question was just, I look at it as the pharmacy being able to dispense this. Is there any pre-care with a doctor beforehand before a pharmacy can prescribe birth control?
Not necessarily. However, if the person does have a primary care physician or a specialist they would like to include in this process, there is a provision for the pharmacist to notify the physician.
Thank you, Representative Farhat, and then Thompson.
Thank you, Chair. I want to take a moment to thank the bill sponsors for this really important piece of legislation. I think it's very crucial for us to recognize that at the pharmacy counter, nearly 40% of Michiganders do not have a PCP. And the pharmacy counter is one of the best ways for us to bridge that gap between healthcare, accessibility, and patient safety. And that's where it happens. It happened during COVID. I want to remind members of this committee, during COVID-19, we asked our community pharmacies to step up and meet a call that was a global pandemic, and they did so safely. They did so by delivering really world-class healthcare. And so I think this is the natural progression for us to look at expanding healthcare at the pharmacy counter. So I want to thank you, Representative Hope and Representative Young, for this. Thank you. And Chair Rogers for being part of this package.
Thank you, Representative Thompson.
Thank you, Madam Chair. My questions are for the pharmacist and the doctor.
Yeah.
We'll arm wrestle over it, yeah.
Shouldn't be that long, right?
You don't know.
Thank you.
Thank you.
You don't know with this committee?
And I apologize, but I do not remember your first name, but this question is for the doctors. So prior to you prescribing a contraceptive for someone, what questions would you ask them to address their background and their medical history?
Sure. My name is Dr. Wallet.
Dr. Wallet, thank you.
So I asked some general questions about their medical health, if they have had medical problems in the past. There are some very narrow questions you might ask about family history, although generally, usually family history doesn't have a significant impact. We may recommend a blood pressure check, depending on the patient's history. But not required to happen in front of me. I usually will ask if they've had their blood pressure checked in the past 3 months. And that's basically it.
You don't ask about a history of blood clots, any type of bleeding disorders, and you don't want to know what their blood pressure is before you prescribe something that increases their risk of high blood pressure?
So that would be part of their medical history, and I ask about problems that they might have, including those things. While we do ask about blood pressure, because blood pressure may increase on some forms of birth control, generally not significantly. So some people in a screening process by a pharmacist who had a history of high blood pressure or who were on high blood pressure medications would likely screen out of the process. That's not the average user of contraceptive. Asking about blood clots as part of the medical history. Blood clots are not very common. While some contraceptives can increase the use of blood clots, actually pregnancy and postpartum increase the risk of blood clots significantly more than using contraceptives.
And then for the pharmacist, how will you be able to, because my history with being in physicians' offices where they have prescribed medication as a nurse and contraceptives, they do run blood work as well to check them for their CBC count, their hepatic function, to see how they're going to tolerate the medication. So for the pharmacist, how would you run those blood tests if you were prescribing that at a pharmacy?
None of those blood tests are required to prescribe oral contraceptives. I'm not sure why your doctor ran
Not
them, but those are
required, but
not
are
standard.
suggested.
Please let her answer the question.
Not required, but
Representative
suggested.
Thompson, please let her finish.
No blood tests are recommended or suggested by major medical organizations before the prescription of a contraceptive.
And what would be those major medical organizations that don't suggest that?
The American College of Obstetricians and Gynecologists, the American Medical Association, the American Academy of Family Physicians. They all advocate for access over the counter and access through a pharmacist because none of those tests are required.
Without access to hepatic function or CBC or any type of blood disorders such as anemia that you would not maybe catch prior to taking that. They don't require that you have any blood work done whatsoever.
They do not.
I'm glad I worked for a really thorough doctor.
Representative Glanville.
Thank you, Madam Chair, and thank you to everyone who's here to testify. I do have a question, I think, for the pharmacist. But first, I just want to respond a little bit to some of the conversation I've heard. At the risk of oversharing, Representative Filler, I myself have been on hormonal contraceptive medication over the course of my life for various reasons, some medical being one of the primary. I also lived overseas for a number of years, and some 20 or 30 years ago, I was able to receive my prescription from a pharmacist in a country where I did not speak the language. So I feel like knowing that this is happening in about half of the states in the United States, this happens around the world and has for decades. I appreciate the concerns people are raising, but I think this has been very well tested and is understood to be a safe method for getting people the hormonal contraceptives they need for whatever their situation may be. And with that said, I do have a quick question for the pharmacist, and just wondering, and maybe this is for the bill sponsors too, if you're under a collaborative practice agreement, is there any issue with how this might work in that setting, or is that something we need to be thinking about in any way?
Thank you for that question. This actually forgoes a collaborative practice agreement. So if it was adopted, this would just include within our scope, so we would not need delegation for it through a physician.
Okay, thank you.
Thank you.
Thank you. Representative Hodsma.
Thank you, Chair Rogers. This is a question for Dr. Wallet. Dr. Wallet, why, if you know, or why, if you can discern, do insurers limit scripts of this nature for 1 month as opposed to a longer duration of time?
Yeah. My pharmacy colleagues say they might have an answer because I don't, yeah.
They're welcome to answer then, please.
Yeah, so sometimes insurers do limit it. It depends on what they're covering in their formulary. However, what we've seen most commonly is they would like the patient to go through like a mail order pharmacy, so they would limit it for a 1 month at the actual community pharmacy and retail pharmacy. So it could be cost related as well.
Thanks.
Vice Chair Whitsitt.
Thank you for your testimony. I think this is an awesome package to be brought forward. And I think a lot of medications should be like this, where you can get a year's supply. As far as wastefulness, I've had medications that I've gotten recently that I've brought them home, and there's absolutely nothing I can do with them because I found there's interaction. So wastefulness does happen, but I don't think anybody's going to waste birth control. My one question is there a pregnancy test that's done ahead of time? That is my only concern about a testing that would be done, because I would think that anybody else who's on birth control has probably been on birth control already.
Yeah, that's a really interesting question. A pregnancy test is not required or recommended for everyone before prescribing of a contraceptive. There can be a conversation which could be had by a physician or a pharmacist about risk of pregnancy. One of the things about oral contraceptives or other contraception is they're providing hormones that are naturally made in the body. And generally, if someone were to accidentally take a birth control pill and they were pregnant, it would not harm that pregnancy. So as part of information about birth control, information about if you're worried you're pregnant, here's how you take a pregnancy test, here's what you might need to look for. And that's information that would be generally provided in package information that could be provided by a number of various providers in the healthcare setting, whether a physician or a pharmacist.
Thank you. I appreciate it because pharmacists always know more than a doctor anyway.
I won't argue. I won't argue.
Moving along, thank you to everyone for joining us today. If you have any suggestions for the bills we heard in testimony, Representative Miller under the buzzer. Last question.
Thank you, Carrie. If a patient is on a prescription, say 6 months in, are you going to be checking up on that patient just for follow-up to see if the medication's working, if there's any symptoms or signs? 12 months is a long time to be on these prescriptions without some kind of follow-up.
Representative Young? Oh, I'm sorry. I thought you were saying you wanted to answer. Dr. Wallet.
Yeah. So generally when I provide a prescription, I make sure someone has contact info to reach out if they have questions, but a follow-up visit at a certain time frame is not required. Reasons to contact their provider or their pharmacist are given, and it's not required to check up. And, yeah,
Can I just add something? As a practicing pharmacist, I work at a college campus pharmacy, and I have the students usually call us and say, we missed a dose, what do we do? I'm seeing this, what do we do? So they're usually following up with their pharmacist probably a lot sooner than their provider, just because we are so much more accessible than their provider. And they can just pick up the phone, call us, and a pharmacist would answer the phone. Thank you.
That's a very good point.
Again, thank you everyone for joining us today. If you do have suggestions for the bills we heard testimony on, please share them with the bill sponsors and my office. Oh, Representative Young, now you would like to speak. Go ahead.
No, I just want to encourage everyone today. There's a big story about over-the-counter birth control. Over-the-counter birth control doesn't require any of the stuff that we're talking about. And so that is currently happening right now. I just encourage folks to do some additional research on that, because what we're suggesting is really safe and thinks about the user. So that was it, Madam Chair. Thank you so much.
Thank you, and I do have cards to read in House Bill 5013, supporting Michigan Nurses Association, House Bill 5435, Pharmaceutical Care Management Association, supporting the bill, House Bill 5435, opposing the bill as written, Michigan Association of Health Plans, 5435 through 5436, supporting the bill is Authority Health. Supporting all three bills, Michigan Council for Maternal and Child Health. Supporting 5435 and 5436, Michigan Retailers Association. Supporting all three bills, Michigan Association of the American College of Nurse Midwives. Supporting all three bills, Planned Parenthood Advocates of Michigan. Supporting all three bills, Planned Parenthood of Michigan again. Supporting all three bills, East Lansing for Emergency Contraceptives. Supporting all three bills, American College of Obstetrics and Gynecologists. Opposing the bill, opposing 5013, Michigan Manufacturers Association. Supporting 5013, Authority Health. Supporting 5013, the Michigan Academy of Family Physicians. And did I see Representative Schmaltz with a quick?
I just want to say, I still think there's a big question here about patient safety, and that is a big concern, especially for younger people. So I would like to take a look at this more to see what we can do to ensure more patient safety in this. That's all. Thank you.
Thank you. And again, if you have suggestions, please reach out to the bill sponsors and my office. I do have a special sad announcement, so I just wanted to give a very big thanks to my chief of staff and who has been my right arm, Ian Mays, who was a key part of this team and executing 25 committee hearings last year alone, and helping me hear testimony on 60 bills. So his last day is this Friday and is not going far, so you can ask him after this committee, but thank you so much for his help. There being no further business. Thank you, everyone. There being no further business before the committee will stand adjourned.